We're now going to talk about continuing our nursing interventions. We're going to talk about care of the patient who's had a stroke, managing their sensory perception. Um, one of the things with one of the nursing interventions you're going to need to do is to make sure that they're adapting to the changes in the sensory perception. Right hemisphere strokes, a lot of times these patients are impulsive and very seemingly unaware of their deficit. Um, they can have unilateral inattention or neglect syndrome. And with that being said, this can be very dangerous. They may not realize they're putting their hand in, you know, too close to something warm. They may, burn themselves. They may um, have trouble remembering how to dress that side of the body. Um, it also can be seen in patients with vision changes because of their stroke, either in one or both eyes. But for nursing, we need to make sure that we're teaching these patients with that unilateral inattention or neglect syndrome to make sure that when they're dressing themselves, that they dress the affected side first, that they are aware of it. They may not be aware of it, meaning that I don't have to think about my right arm. It's just there. But we can reteach them how to, I need to make sure that my right arm is well supportive. I need to make sure that I place my right arm up on the table on a pillow. Things like that. So when I say that we can teach them how not to neglect it, it's by teaching them that they need to do things that they used to not have to think about. Best way I can give an example, or like I am painfully left-handed. I do very little with my right hand, but I know it's there. I know that my watch is on it. I know that obviously talk with it, but if I had had a stroke and it affected that right side, I could be taught that I need to make sure that I'm supporting that arm, that I'm dressing that arm first, that when I lay it on the table, that I make sure there's nothing sharp underneath it, those kinds of things. So I can be retaught to care for something that I used to just take for granted. Also with the vision changes and with sometimes this intentional neglect, you want to make sure you're placing objects within their visual field to make sure that they're able to see them, and make sure that you're asking them. A lot of times with the unilateral intention and neglect syndrome, sometimes use of mirrors will work. You teach them how to address that affected side first. Difficulty with visual perception and spatial perception is also usually right hemisphere, and that can be difficulty with ADLs. You always approach the patient from the unaffected side, which is also should always face the door to the hospital room if at all possible. Again, you always approach the patient from the unaffected side because they can see you on that side. And make sure that if at all possible that that should also be the side that is facing the door to their hospital room. Nursing interventions for care of the patient with stroke. Again, we're still talking about sensory perception. We're on the left hemisphere now. These patients a lot of times will have memory deficits, and they have inability to carry out their ADLs. But their ability to carry out their ADLs is usually something from apraxia, where it's the inability to perform a particular purposeful task, such as they may not remember how to put on their shoes. They may not remember how to do something. A lot of times men forget how to shave, things that they've been doing for years. That's a lot of times what you'll see with the left hemisphere stroke. They need to be reoriented often to time, place, and person, and they need to have an established routine to help with those memory deficits. Also, a lot of times it's useful to put names of objects on them, and to perform the help with the ADLs in the same way every day so the patient can relearn how to do them themselves. So a lot of times the physical therapist or the OT will help to establish what these routines will be, and they'll write them out so that no matter who the caregiver is that day, they're able to provide them in the same order. Continuing with stroke care and nursing interventions, looking at patient education and home care. We need to make sure that we're educating both the patient and their caregivers on the risk of depression, especially about 3 months after their stroke. The 3 strongest predictors of post-stroke depression are a history of depression, the severity of the stroke, and post-stroke physical and cognitive impairment. These are all will put them at a risk for depression. A lot of times family will have guilt because they didn't get them to the hospital in time to have in block therapy. There'll be a lot of self-doubt with their caregivers. There's a lot of guilt sometimes with stroke patients, and sometimes with their families. Maybe they're not able to care for them at home because the patient's physical needs are greater than can be performed in the home. A stroke puts a very much a tie or a weight on the family unit to figure out how they're going to care for this loved one at home or whether it will be in a facility. So, but then the patient themselves usually is at risk for depression about 3 months after the stroke. And again, the 3 strongest predictors are history of depression, severity of the stroke, and post-stroke physical and cognitive impairment. You want to make sure that if they're going home, that they have fall safety in their home or fall precautions. They have the handrails they need. They have learned how to walk stairs if they have stairs. They've removed throw rugs. A lot of times these patients will go into a nursing facility for rehabilitation, and this is the time when the family will get used to getting everything ready at home to care for them. So, and they need to work with the physical therapy team as far as we have steps in our home to see if it's going to be obviously if they're going to be able to get the patient home because of the safety requirements of someone who's had a stroke, making sure they do have the handrails, in the bathroom, by the toilet, make sure that they can get up and down stairs safely, and you want to make sure you don't have any throw rugs on the floor. Continuing on with that patient education and home care, there are a lot of home care resources and healthcare resources from the American Heart Association that are available to patients and their loved ones. You want to make sure that you're teaching both the patient and the family the FAST mnemonic, which is facial drooping, weakness in their arms, speech difficulties in their speech. And remember that time can be a factor. You want to get them to the hospital fast, so you want to call 911. You want to make sure that they understand their medication regimens and their modifiable risk factors so that they can prevent an additional stroke. In conclusion, stroke care for the patient starts before they ever hit the emergency department. It starts at home. It starts where they are, whether it's at work. It starts with someone recognizing that they have either facial drooping, that they're having a sudden change in their speech, that they're calling 911 in a timely fashion and getting them to a stroke center in a time that they can have fibrinolytic therapy within that 4-hour window. that is the critical care part of it. So that is what will be covered in 495. But I do want to make sure that you are well aware of the community resources, that what the community needs to know about a stroke. Look back at those 10 symptoms of a stroke. Make sure you know the 5 common symptoms of a stroke. Make sure what education needs to be out in the community, both for women with strokes, with just strokes in general. What are the modifiable risk factors? What are the non-modifiables? Which ones need to be treated? And if the patient does have a stroke, after they are out of that critical, the only thing that I really want you to be concerned about during the acute phase is making sure that about their nutritional needs, make sure that they're on thrombolytics, make sure that they're following the J-code guidelines, make sure you know what those core measures are, and then make sure that you're ready for care of the stroke patient. And that's about it. If you have any questions, please let me know.